tens of millimeters, okay? And calculating together the AP position plus vertical control of the joint. So, and what keeps the mandible in class 1? Exactly that retrusive control that usually can give to us is the first bicuspid. So the first bicuspid guides us a lot to stay in class 1. So in class 2 high angle cases, when we have a lot of double occlusal planes, we have here posterior occlusal plane completely different than the anterior occlusal plane. The main goal here is to decompress the joint, doing a vertical compensation, dental alveolar decompensation, and articular compensation. So basically, is to remove the interference on the anterior incisors, the anterior teeth, the incisors, and upright the lower teeth. Uprighting the lower teeth, I will remove all the interferences that being caused the mandible to stay back. And after that, I create my compensatory mechanism with my overlays to maintain the mandible forward. And the next step is to bring the teeth together with the brackets, okay? So like this and this. So I have this case I received in my office. It's a very hard case. It's a syndrome patient. He came with this situation. I didn't bone the brackets like this. This is the way he came, okay? With a very, very big open bite. Severe case. There's no space for bicuspids, completely no space for bicuspids. And his narrow arches really is correlated for his syndrome. And the presence of the third molars and all the posterior teeth mesotiped on the lower jaw. Okay, his very high angle case, condyles flat, not so bad, but flat. And you can see here a lot of interferences on the molar, and his open bite is very severe. So when we trace, we have 13 millimeters of convexity with dramatic case. The family refused surgery. I would say to be good. We need to finish this case surgery. The family completely refused. So I will do my best with my brackets here. Let's see what we can do. This FMA is 56. I never see an FMA like this, first time, okay? So we put his multi-loops with gum metal. This is gum metal alloy. The multi-loops gum metal alloy to tip back the lower dentition to upright them. And little by little, I put here like a T-loop to open space for canines. This way, he was progressing. I made here like an overlay wire to help transversely the upper arch. And took new records to evaluate the uprighting. So now the posterior teeth is very uprighted already. It's the way I planned it. After this, we finished to open the space for his canines. His mandible is much better in space. Now is the time to place the canines in. So before this wire, I made here a little nickel titanium just to help a little bit. And now we got back the multi-loops with the gum metal. And this way we move to finish his case. Doors like this way. And when we got his almost class 1 position, he got the class 1 here. When he got the class 1, I still feel a click in his joint, on the right joint. And sometimes I'm crazy because I think anybody in the world is gonna finish like this. But I made now a new overlays for him to open his bite more. Why I open his bite a little bit more? To decompress more the joint. Remember when we put the overlays on number 7? What happened to the condyle? The condyle moves down. So this is what happened here. I asked him to put anterior elastics to decompress the joint a little bit more. And he did it. He was a very good patient. And after we start to close his bite, which is very quick, is 2-3 months, he closed the bite. And this is the way we finish his case with some restorations on the incisors. Now I'm waiting for him to set down the system, make his gingivoplasty, and I will finish with a new restoration and make his incisors a little bit bigger because his incisors too small, okay? So this is the before-after the treatment we placed. The low-angle class 2s is a little bit harder to treat because those are let's say the biggest challenge we have in our specialty, because it's too hard to treat and too hard to maintain the patient low-angle class 2s. So basically, we need to understand what's going on, but we're gonna also pass through unload the joint, increase posterior dimension, and also increase the vertical anterior dimension because we need to remove the deep bite, and reposition the mandible accordingly, sometimes a little bit forward, sometimes a little bit more, sometimes a little bit less, case by case. If needed, of course, let's upright the dentition, reposition the mandible in the desired compensation that we want in a therapeutic position, create our overlays to maintain that position. Sometimes I need overlays on the 7, sometimes overlays in 6, simultaneously. And now it's a matter to put the bicuspids together. And once we have bicuspids together, we can remove the overlays and put the molars together, and that's it, okay? So, like this case, for example. The case is very sensitive in her muscles because the mandible is very back, very short angle case. It's very common to appear cases like this after 4 bicuspid extraction, very similar situation. And this is the hardest challenge because we need to disassemble the puzzle to understand what the other doctor did. And plus, extractions is not so easy to stabilize the mandible. But this case wasn't the case, but because she had the bicuspids. But she was one missing molar in here. This was a tough case because the one missing bicuspid, sorry. Tough case because she was very over-rotated mandible, super deep bite, very, very hard case. So we mount her case in therapeutic position. RP, ICP, now in therapeutic position, reference position here. We calculate his movement, her movement, sorry. And with the multi-loops, we started to recreate a new vertical dimension for her, unlock the mandible as best as possible, remove interference of the incisors because the incisors was very over-erupted. And after I remove interference of the anterior teeth, I am able now to recreate a new mandible position. So we create the mandible forward 4 millimeters both sides to reposition the mandible. We wax up her molars in a new position. So we create the therapeutic position with wax. This is another way we sometimes do. I mold the wax with the transparent silicone like this. We pour soft composite, put in the mouth like cure. At that time, I used this red and blue composite. Now I don't do this because it's too soft in the patient brucks, and you need to redo this many times. So there's some other new ones. I like to use one from Fuji, which is very, very good one. So it's very soft and very solid, very, very, very tough composite. And here is her therapeutic position of the wires, and after some elastics, we got this position. So from here to here is pretty quick. It's not really a long time, and we can obtain this position just 3 months, okay? So we can jump the bite very quick with the aid of the overlay. So we can completely change the face of the patient and her comfort on the muscles, just before after, and before after the mandible position. So this is something we can do in low angles. Can you do this in kids as well? Of course, it's the same concept, but now we have deciduous dentition. It's much easier, okay, which is really much easier. So it's a very retrognatic mandible, and the mandible shift to the left, and she has no space for lateral incisors, and she has a full body compensation, okay? So when you see her inside mouse with CD bite, the mandible shift to the left, no space for the laterals, class 2, and she's very short lower facial height, she's about 41. So when we create her therapeutic position, we reposition the mandible forward, and this is her ideal position. If you look here, we have a big gap between upper and lower dentition. So what is the goal here? What is the target here? Is to fulfill this gap, okay? So how can I fulfill this gap? Let's use the deciduous dentition. Thanks God, we have milk molars here, and they will drop, they will exfoliate. I like to make a bite test for the patients like this, just to check if her muscles are good, if it feels good, there's no problem. I place the bite test, she's capable to get that position. After that, we create her new crowns, okay, new overlays. We cement the overlays and reposition the mandible automatically, so there's no need for brackets, no need for appliances. Sometimes my students tell me this is not orthodontics. I tell them that this is dentistry, okay? And this is 46, the new lower facial height, which is I planned. So we jumped from 41.9 to 46.5, and which is exactly the way I want. I follow up her. This is about a month something after. This is exactly, yeah, here's 1 month after. This is same case 3 months after. Oh, look at that, it's open space for the lateral. I didn't expand her. There's no quadrilex, there's no removable appliances, there's nothing in her mouth. It's just occlusion. Occlusion in new position. Occlusion in new position means a phrase that reminds me of Professor Ricketts. He always says to me a very important phrase when I was his student. Nelson, never forget to recruit the forces of occlusion. I always remember this phrase, but I was too young. I didn't have any maturity to understand this phrase. What is recruit forces of occlusion? This is forces of occlusion in action, because I create a new environment, new forces for masseter, for temporalis, for lateropterygoid, medial pterygoid, muscles, nerves, vessels, ligaments, working here. So 3 months after, she has space for lateral incisors, okay? So 13 months after, the incisors start to erupt. So good, I'm happy, very wonderful. And look at what happened to her frenum. Disappeared, okay? There was no more high frenum because the dental alveolar bone grow. So the soft tissue stay, but the bone grow because I give to her higher vertical dimension, okay? So little bit later on, oh, her name is Karen. Karen's becoming with the teeth. Now she's happy because her lateral incisors are erupting. So happy, Karen. And she disappeared in pandemic. Okay, she disappeared during the pandemic. And I spy my patients on Facebook, to be honest to you. And now she's 3 years after, and I took her Facebook picture. And now she's like this. So just 4 pieces of acrylic, I completely changed her condition, okay? So this is all matter of recreate the mandibular reposition. Sometimes we have those cases, I finish class 1, but sometimes you look to the patient go back to class 2, it's like dual bite, patient bite in class 1, class 2, class 1, class 2. It's a matter to recreate a new retrusive guidance to the first bicuspid. This is why I don't like to remove first bicuspids, because they are very important. They are not supernumerary tooth, okay? And what about class 3? What can we do with the class 3s? Class 3 basically is control the vertical, pure control the vertical dimension using rotation. So we're gonna use the lower compartment of the joint, okay? So how can we do this treatment? Is rotate the mandible. Once you rotate the mandible in RP position, please, it's not aleatory. You need to have the patient recorded in RP position, the articulator, okay? So in RP position, I am able to rotate the mandible the amount as I want, but now, according to the Japanese paper, I will make my overlays on bicuspids, okay? Why? Because I want to maintain the mandible rotated. I don't want to decompress the joint. I just want to rotate, okay? Once I make my overlays, cement your overlays on bicuspids, okay? After that, put these together. Can be with sectionals, can be with elastics, can use your creative mechanic. I know you guys are very creative, you're Vietnamese, okay? After that, you remove the overlays, put the bicuspids together, and that's it. So look at this case, for example. This guy has no incisors displayed, but believe me, he has these, okay? But he doesn't show, okay? Because he's class 3, typical smile, class 3 patient. They usually don't show the upper incisors, okay? Why this is happening? Because the mandible is normally super over-rotated and impede the eruption of the upper incisors. Muscle palpation, no findings. But poor guy, when he smile, we cannot see his teeth, but here is his teeth, okay? Here we are. He has everything, okay? So when he's moving in closing contact, he touched the incisors and slide back the mandible in maximal intercuspation, okay? So how can we help this poor guy? When we make occlusogram to him, we can see a lot of prematurities on the anterior teeth, especially when he goes to maximal intercuspation. So his first contact happens on the canine, and when he closes, touch and destroy the whole wax because the incisors contact and the mandible moves back. Even in this kind of class 3 design of faces, negative convexity. Great, we took his combine. I don't want to stay here too long, but his airway is very poor. You can see his axis is inclined as well. There's no really volume for airway. Condyles are a little in trouble, but not so bad. A little decorticalization here on the left side. So we mount his case in RP. In ICP here, we compare. So from this position, we can design. I'm gonna move a little bit quicker because I have a lot of studies of this case. This is his Brooks checker. This is exactly where he brags on top of incisors. His condylography is very important to understand how is the pathway. He has no problem, absolutely no problem, but he's very difficult to stay with the mandible posterior position because of his compression. So we designed his new lower facial height at 40 degrees. So when we put the 40 degrees, the system tells me that I need to raise the pin 5 millimeters. So this is his therapeutic position with 5 millimeters. And I have also a little articular compensation because the left side joint was under compression. So we move his mandible forward 2 millimeters to decompress the joint, even if in class 3. Sometimes I need to reposition the mandible a little bit forward to decompress. And this is the way we made his calculation, okay? So we decided to work with him in exactly 5 millimeters of pin. And this is his bite test in position. We cement his crown overlays, so you can construct in a computer. You can use the computer, no problem. Cement the overlays here. And now what happened to his bite?